welcome you here today to this program that's organized by the Center for Healthcare Management and Policy at the School of Business. And we have a very exciting program. We have 4 CEOs and presidents of healthcare organizations and insurers in Orange County. And they'll be talking about the impact of the Affordable Care Act on excuse me, hospitals, physicians, physician groups, and insurers. And after the formal presentations, you'll have a time for a question and answer and discussion. But before, excuse me, but before we start, I want to just make a few announcements. For those who have been here for our February conference, it's on the website if you wanted to look back at any of the speakers. Today's session will also be on the web and very shortly afterwards, so if you wanted a review of what some speakers said, you can go and look at that on the web. We are recruiting for the Healthcare Executive MBA class for this coming fall, and so we're still accepting applications, and if any of you want to find out more about it, Joanne is over there with her hand up, and she has a little booth out there, and just drop by and talk to her. This fall, we're also planning for sort of a small half-day conference on wireless health applications in healthcare, and we'll let you know more about that. So without more of my time, let me introduce our moderator, Terry Belmont. Terry is the CEO of the University of California Irvine Medical Center and the ambulatory care clinics located throughout the area. Before that, he was the CEO of Long Beach Memorial Medical Center and the Miller Children's Hospital, and before that, he had several top executive positions at other institutions in Orange County. So without any further ado, please join me in welcoming Terry.
Thank you, Paul, and thanks to the Paul Merage School of Business for putting this together. I think the school is doing a lot of work in terms of educating all of us and giving us a chance to have exchanges in healthcare. So I really appreciate that very, very much. And it's great to see so many friends, colleagues, and family here today. This is a really great group. And the attendance here really shows the absolute interest in what's going on with the Affordable Care Act. And we get a special, and things are happening so fast, by the way, in this, and it's really good to have these, get some updates from individuals who are taking leadership roles in formulating our new healthcare system over time. So it's great to have this opportunity. I'm just wondering, how many of you are not from Orange County? So this is, okay, thank you. So this is really Orange County focused, and that's really good for us. I think that's really good for us to be able to do that, because I think, and I was speaking to a wise individual recently, talking about the fact that as this change is going on, as we're moving to a new system, that we really have to keep, I think, keep in our minds an Orange County solution. We really have to survive, yes, all of our individual organizations, but we're here to treat people. And we have the unique opportunity to treat over 3 million population here in Orange County. And so as we do things, we need to think of that 3 million people and an Orange County solution. So with that, it's my pleasure to be able to introduce each of our panel members, and they're gonna take about 20 minutes or less to share some of their thoughts, and then we will have the opportunity for questions and answers at the end of that. And you've read, I think, the biographies of each individual are in your packet, so I'm not going to go over those. I'm just going to introduce the first speaker, Rick Afable. Rick has been here in Orange County, made a major impact here in Orange County through a lot of the activities he's led, through the work he's done with Hoag, and of course now together with St. Joseph Health has put together Covenant Health Network. So Rick has the huge job of developing the Covenant Health Network, as well as being Executive Vice President for the Southern California region of St. Joseph Health. So, and St. Joseph Health, yeah, I think that's the way to say it, and you'll clarify that more as time goes on. So Rick, welcome, glad to have you here.
Terry, thank you so much. My pleasure to be here. As I look around the room, I see many, many people who could give this talk. So that means that what I'm going to be doing is to kind of sharing some of my thoughts, but you have thoughts too. And so I'm very hopeful and expect that we're going to be sharing those thoughts over the next hour to hour and a half, because it is in the sharing of our collective opinions and desires and wishes that we can do just what Terry said, which is to grow healthcare here in Orange County in a way that we all want and that we know our community needs. Let me just acknowledge, if I might, Margaret and Paul. Thank you. Margaret and Paul do the thinking to get us together so that we can have events like this. So Margaret doesn't get a round of applause too often, so I think we should give Margaret a round of applause. It was about 3 years ago that we had a meeting right in this room, and there was a few of us on a panel here, and the discussion and the talk was healthcare reform. What does it mean? Or something like that, some catchy. Margaret thought of some catchy title. And at that time, we were talking about a whole host of what ifs. What if this? What if that? All kinds of what ifs. And when you think about all the things that have happened from that time, from that moment till now, it is amazing. It is amazing how far we have come. Because for those of us who've been around long enough, in the mid-'80s, we talked about the what ifs, and they didn't happen. And then in the early 90s, we talked about the what ifs, and then they didn't happen. And then, through the late 90s into the 2000s, early 2000s, there were some what ifs, and most of those didn't happen. So 3 years ago, we were talking about what ifs, and there were a lot of people in this room, myself included, who thought, well, it's really not going to happen. It happened. It happened. And so the very concept, the sets of concepts that we had been discussing at this setting just 3 years ago, many of them have come to fruition. And we are now in the middle of and about to embark upon the major elements of healthcare transformation that are going to change everything that we do for those of us who are in healthcare or receive healthcare. So who is it that it's outside of the setting of either providing healthcare or receiving healthcare? It's everybody. It's our entire community. As I think about the Affordable Care Act, which, by the way, I hope I have a few moments to speak to the fact that I think most of the healthcare transformation is actually related to the Affordable Care Act, but not due to the Affordable Care Act. And we'll touch upon some of those things, I'm sure, in the next hour, hour and a half. But the Affordable Care Act, I think it's important that we establish what it is. It is a program to expand coverage and to eliminate financial barriers to healthcare services. There are some other minor tweaks to it, and there is the Institute for Healthcare, there is the Center of Medicare and Medicaid Innovation, and there's some of the pilots in the Pioneer ACOs and other forms of ACOs and bundle payments and a host of those sorts of things. But those are not the core elements. The core elements of the Affordable Care Act are the elimination of the financial barriers to care. And in California, we expect that as many as 7 million people are going to now have access to care from a financial perspective, meaning that the barriers have been eliminated. We will have a vast expansion of Medicaid. And then we will have all of what the exchanges are going to be about. And we know that in California, we have the most mature, the most advanced, and the most likely to implement on time health insurance exchange in the country. Okay? And it will be on time, by the way. So speaking to those who are doing the work for the California Health Exchange, known as Covered California, It will be on time. We will have people enrolling in October. Not every element may not be available for January 1, but it will occur. It's here. It's here. And it will have an effect on everything we will do. But when we talk about the Affordable Care Act and whether it'll work or not, I think there is no question that for its core tenet, which is to remove the financial barriers that exist that prevent people from having access to care, it's going to do that. So it will do that successfully. The problem with what we have designed is it doesn't really address the care elements very well or in enough depth to make a significant difference, because the difficulty that I have personally is that, yes, we have 5 million people are going to sign up next year, or let's say between October and December, 5 million people, hopefully, for the state will sign up, because, by the way, what Chris is going to tell us is that if we don't get enough people signing up, the whole thing doesn't work, right? So the sign-up is critical. So we want everybody, whether you were for it or against it, since it's here now, we better get everybody to sign up, because if people don't sign up, the whole actuarial model just falls flat, right? So I'll leave that part to Chris. But we have provided access, but one has to ask the question, access to what? Access to what? We already know that the current system, the one that I work in, and the one that many of you work in today, is fragmented, lacks coordination, is rife with waste, not because people are being fraudulent, but rather because the system is not sufficiently integrated. We can't do anything but be wasteful because we don't have access to all of the information and all of the coordination elements that are necessary in order to make the thing work. So what we've done, what the Affordable Care Act has done mostly, that is going to need to be corrected over time, and this is where the big corrections are going to happen. What the Affordable Care Act does is it removes the financial barriers to a system that doesn't work very well. So we've taken up one big part of it, which is the access piece and the elimination of financial barriers, but what we haven't really worked on in a very intentful way, in a very significant, specific way, are the elements of care. So what does the Affordable Care Act then mean for hospitals? And I'll address it from the hospital perspective, which is my task as a member of this panel. Hospitals are component parts of what we've already said is a discordant, uncoordinated system of care. An important part, obviously. In fact, some would say, historically, at least for the last, let's say since 1965, since Medicare was initiated, the most significant part and the most visible part of what healthcare has been about in, we'll call it the modern era of healthcare since the mid-1960s. It's also, by the way, the most expensive part of healthcare and healthcare delivery. But it's a healthcare delivery system that those of us, we all know so well in the hospital industry, which is we work backwards. What I mean by that is that in the hospital industry, what we do is we wait for people to get sick and then we treat them. We wait for people to have an emergency, and then at Hoag Hospital, 70,000 times a year, we take care of them. At Mission Hospital, 50,000 times a year, we take care of them. At Orange, over 100,000 times a year. People come with a problem and we take care of them. It's a retrospective view of care, and it's a fine system if that's what we are intently trying to accomplish, right? And so physicians who are in the healthcare system, and Dr. Wilson is going to speak to that very specifically, are except for those who are involved in what we'll call managed care or prospective payment models, are mostly participating in this retrospective system of care, which is the very essence of the lack of integration and the lack of coordination that exists. What will have to happen then as the Affordable Care Act is enacted is that one of two things are going to have to occur that are going to affect and do affect hospitals very specifically, and we have to react to this and we have to take action. We have to make a decision. Either number one, if we continue to work in a fee-for-service, retrospective, let's mostly wait for people to have health needs addressed, we know that because healthcare lacks coordination, there is a cost to that lack of coordination, to the lack of of coordinated care. That cost has to be borne by those parties who are paying for it. And in this case, with the Affordable Care Act, it's all of us. It's essentially the government paid for by us. And so the only way that that can be managed, the only way the dollars can work is by reducing the payment per unit of service. It's the only way it can work, right? So we're expanding these systems greatly, but we know that the cost has to go down. If we do nothing to the care part, or we do an insufficient amount of change to the care part, the payment per unit of service has to go down. So hospitals have to make a big decision, and the big decision is, can we, in a retrospective, let's wait for people to get sick mode of thinking or operations, can we reduce our costs sufficiently that we can actually survive in the payments that are coming related to a diminution of payment, related to the retrospective fee-for-service, if you want to use that term, system of payment. Because remember, the Affordable Care Act is a system of payment. It's removing the financial barriers to provide for access. So that's a big decision. I can tell you for hospitals like Hoag, for hospitals like Mission, that's a big challenge. And the reason it's a big challenge is because we have spent decades trying to build up what we provided better, private rooms, view of the harbor, right? All of these elements are all things that in a pay-as-you-go market system could be desirable, but in a system in which there's downward pressure on payment, not so much, not so great. And one has to think, for an organization like Hoag, as to whether it is willing to change its identity based upon a change in the services that it provides in order to create a financial model that works. Or there's another side to the question. And the other side to the question, and the other answer could be, we're going to move away from a fee-for-service retrospective view, and we're going to participate in the true transformational elements of healthcare reform that we think are on the way, which will be a reaction or a response to what the Affordable Care Act has created, which is care coordination, management of care and services. The buzzwords today are population health. Do we get into that element and take a different view as a hospital and say, okay, we're not just going to sit there as buildings and places where people, when they get sick or have a problem, can come and receive. We're going to still do that, of course, and we know that the business model is going to be difficult, very challenging, because we're going to be paid less per unit of service over time for that. And do we get into and create a different business model? Because there will be a need for a different business model as it relates to the clinical models of care. So if the clinical model of care is care coordination, prospective assessment and analysis, and understanding of population and their needs, understanding what individuals are going to need on a very specific way using tools and new technology that can become available, we could actually create a system in which we would be looking at what is the budget for the care of a person or a population, and then what is it that what's the best and the most that we can provide for those individuals and for that population in order to provide for them everything that they need to the best of our abilities, and to try to minimize as much of the retrospective care as possible. That's a different business model. It sounds like managed care, doesn't it? The difference, however, for me is that managed care was let's sign people up and provide as little care as possible. That's a successful formula for managed care. Let's sign people up, let's collect their premium, and let's try to minimize the care that they receive. That's organization's been successful on that for decades. The care coordination and the care model that I'm speaking to is one in which we would assess from a clinical perspective, not from an actuarial perspective, although they're related, a clinical perspective such that we would begin to understand what are the needs of a person and then those persons that come together within a population, and let's build the model that can provide for that. Generally speaking, that would not include a lot of operating rooms, or it wouldn't be ICU beds, or it wouldn't be a big ER. And it wouldn't be, by the way, I just described a hospital, didn't I? I just described a hospital. And you would think differently and you would go differently. But you would proactively go forward and move that. There's a problem, however. The Affordable Care Act does not yet contemplate payment in that way. There are some pilots and there are some little projects and experiments within the Affordable Care Act, but for the most part, and in California it's very much the case, the exchanges are going to pay mostly on a fee-for-service system. And a fee-for-service system promotes retrospective illness-based care. It doesn't promote the kind of care coordination that I just described. So for hospitals, we have to make this decision, which is, are we going to hunker down and become low-cost providers of hospital-based services, and that we will be mostly in the 4.2-day business? And does that mean we have to change our menus at Hoag Hospital? That maybe we have to, take away the views because we're going to use the view rooms for the hotel services, and that the patients will be looking out the other direction maybe? Being facetious, of course, but one has to be thoughtful about how a model that is built upon something like a expansive fee-for-service can actually survive in a diminishing fee-for-service, not an expanding fee-for-service world. And then the second is, how do we address then this care coordination model? Well, what hospitals are doing all around the country, how are we doing? Okay, we got 5 minutes. What hospitals are doing all around the country is they are coming together in order to address the opportunities in care coordination that we believe will provide for at least a few things. Number one, an ability to survive, but more importantly, thrive in a healthcare payment model, changes in the payment models that are impending for us on the fee-for-service side. The second is, most of the people that I know working for hospital systems are very happy about this change. And the reason is because we feel like we're finally getting down to and around to what we really want to do in the first place, which is to take care of people, as opposed to hope that we can get doctors to refer sick patients into our buildings, which is what we've been doing for the last 50 years. And so there is a great excitement about the prospect of what this could mean. But there's also a great fear and concern because for most hospitals, we've never done this before. And it also requires partnerships and relationships that we've never had before with doctors, with health plans, with communities, long-term care, pharmaceuticals, distribution channels, and a whole host of other elements that have never been necessarily in the fold as it relates to what hospitals do. So the transformation then that's upon us is the financing changes, the financial changes of the Affordable Care Act, and the prospect of a changed healthcare environment that sees hospitals as a very prominent part of the healthcare infrastructure, changing the ways by which we function because of not the hows and the whats, but the why. Because the why element of what it can mean and does mean is what the Affordable Care Act is now putting upon us, which many of us believe in a very, very positive and creative and constructive way. I'm sure we'll have more conversation, and I would look forward to your questions. Thanks.
Thank you very much, Rick. Very stimulating and really gives a great overview. And this is really a great panel because we do have someone who's really sharing on the provider's standpoint. And actually now we have Keith Wilson, who has been working in and around Orange County for over 21 years, so he knows us well. And Keith was president of Talbert Medical Group, and now is president, as you know, president of the kind of all the medical group operations for Molina Medical Care, Molina Medical. So at this point, I'd like to invite Keith up and welcome you.
Thank you. Good morning. I share some of Rick's sentiments. I've been around Orange County for a long time, and I'm looking at the audience and seeing a lot of people who I touched in my career and who sort of nurtured and grew me as I was a young doc coming up and sort of learning management and managed care. I'm going to talk from the perspective of physicians, both from a managed care perspective and a fee-for-service perspective. And I'm going to talk about some of the opportunities I think the Affordable Care Act has created in terms of forcing docs to think about healthcare differently. And I think Rick made some good points, and I'll probably touch on much of what he said, in talking about how the system of care and the system of delivery of care has to evolve, has to change. And docs are feeling this pinch more than most groups, more than most people. I'm just kind of curious as I look at the audience, how many docs in the room? Okay. How many of you are solo practitioners? 1, 2, 3. How many of you are parts or members of IPAs? Okay, a few more. How about group model physicians? Okay. All right, so healthcare is changing, and the Affordable Care Act is given a lot of credit. I do want to just kind of make a point that I think healthcare was changing before the Affordable Care Act came along, and that it was changing really in response to some forces in the market that have been going on for a long time. If you look at this graph, you've seen it before. It shows the baby boomer generation coming. Back in 1946, you had 65 years. You got 2011, and we know the impending cost of health care related to the senior population. What you don't really think about is this piece right here, where the population dipped. And what does that mean? What it means is we have a ramp up in seniors needing care, but a decreasing number of workers available to provide the support for that care. And that's really stressing our system. And when you push that out a little further, you see that healthcare and Medicare has been in trouble for a long time. We've always projected sort of a demise of Medicare from a funding perspective, even before ACA came about. And if you pay attention to that graph, you'll see right before ACA was implemented, it was at its shortest expectation of life ever. And so the ACA Act actually put added some years to the life expectancy of Medicare. The other thing we've been dealing with, and I've been in physician group management for a long time, is the increasing lack of affordability of health care. And if you pay any attention to that graph, it's that those lines are divergent. People's incomes were not keeping pace with the cost of health care, and so health care was becoming increasingly unaffordable. And that had consequences. We'll talk about some of those consequences in a few moments. The cost of health care in this country has been out of control compared to the rest of the world for a long time as well. That's not a new phenomenon. The United States continues to lead all industrialized countries in per capita cost of care and has done so going back many, many years. And you'll notice that the last bar on that graph was 2008, which also precedes the Affordable Care Act. So these are sort of the forces that created and drove the need, the demand for healthcare reform. And so now healthcare reform is here, sort of reactionary, and we're talking about it, I think, as though it's the stimulus or the reason healthcare is changing. It's really a reaction and not so much cause. This graph you all have seen before. I just put it up there just to sort of bring it full circle. And we know today, healthcare is about 17% of gross domestic product. And if we push that out for another couple decades, it'll hit 38% of gross domestic product. And so we talk about, in these kind of rooms, what can we do to bend the cost curve? This is the curve we're talking about, because everybody knows that if we get to this point, things have to, I don't know. What do you think? Can we get to that point? I don't think we can get to that point. Something has to happen between now and then. So do we have the best healthcare system in the world? As I've sat around dining room tables and spoken to my friends about, why do we need change? Why do we need healthcare reform? Our system of care is great. And my answer to them is it depends on where you sit and what kind of coverage you have. If you look at even something as commonplace as infant mortality rate in our country, you'll find that United States, even though there are a lot of countries that aren't on this list, ranks somewhere between 40 and 50 in the world in terms of having the highest infant mortality rate. And even then within our own country, you'll see that there are some states that have twice the infant mortality rate of other states. And so we don't have a homogeneous approach to healthcare. And from that perspective, we don't do well. And if you look at other things like life expectancy, you'd find similar kinds of results. It also depends on where you sit on this curve. We don't have a uniform distribution of availability of healthcare. There are people that sit on the gray side of this scale that are very happy with their care, and the gray side of the scale, where we're talking about commercially based products, these people do get good care. I'm one of those, so I'm not complaining. But there are people then that fall into black, and it's a disproportionate number of people that fall into black depending on ethnicity and income status. And so what the Affordable Care Act is probably going to do, or what it will do, it will change sort of the blend here on this graph. You'll have more people in shades of blue with government-covered care, reduced unit costs, and I like Rick's choice of terms there, suppressing unit costs, but actually increasing and pulling people out of the black, increasing the number of people that have access to care. Whether you are comfortable with the care that you have access with, a lot depends on your status in society. If you're poor, you have a different perception. If you're a minority, you may have a different perception. But healthcare as delivered in our country is not uniform. So getting to the Affordable Care Act, which is what I'm here to talk about, Don Berwick sort of coined this phrase. If he didn't coin it, he popularized it, and that was the triple aim. And so I decided to kind of sort of structure my talk in the three buckets that he referenced. Improving the experience of care, improving the health of populations, and then obviously reducing the per capita cost. So if we go to expanded coverage, and I think that, as Rick just alluded, and I think Chris will talk to that a bit more, and I'm going to pull out my notes because I can't keep turning around and reading over my shoulder. Coverage is obviously expanded. Millions of people who have been uninsured will become insured. One of the things that I think the Affordable Care Act has done and will sort of accelerate is the modernization of healthcare. And if we look at healthcare, historically it's been a cottage industry with doctors just setting up shop. And if I ask that question, how many of you are in solo practice 10 or 15 years ago, most of the docs in the room would have raised their hand. And so we've seen healthcare transform as we speak. And if you talk about unit cost, you recognize that if each doc is supporting their own infrastructure, their own bricks and mortar, their own work staff, that's not a very efficient model of delivery. And so we've seen sort of increasing consolidation. But one of the things the Affordable Care Act has done, and I'm going to try and stick to my notes and not get ahead of myself, is meaningful use. Meaningful use has been a great incentive for physicians and physician groups to invest in technology. And technology that starts with electronic medical records opened the doors to more advanced evolutions of healthcare, moving toward population management, risk management. And you need these things. If you're going to do true population management, you need disease registries, you need data warehouses, you need the ability to know who in your population is at risk for any particular diagnosis, and the modernization of healthcare has done that. So that's a positive aspect in terms of improving the experience of care. The negative, I think, is the disruption, because along with retooling healthcare, patient care is disrupted. Sometimes the sacred patient-physician relationship is interrupted, as patients have to choose different delivery systems, different models of care. Sometimes it also requires them to shift doctors. If you remember the experience when California decided that they were going to take all of the SPD patients, seniors and persons with disability, and put them into managed care, that was a very disruptive process. Probably as much as half the patients ended up with a different caregiver after that process was completed. And if we look at the duals, and the automatic patriation of duals into managed care, a similar disruptive event will probably occur. So that's disruptive. Accountable care organizations, while not on the surface are disruptive, at least for the primary care doctors, they are disruptive potentially for the specialists, because an effective accountable care organization is going to direct patients away from high-cost specialists and towards low-cost specialists or more efficient specialists. And again, another disruption in care. So physicians are reacting to a changing landscape. We've seen group consolidation. And if you think about it, group consolidation was inevitable. My group sold to a larger group. When I ran Talbot, we sold to HealthCare Partners. Monarch sold to Optum. Bristol Park sold to Memorial Care. And the list goes on and on. And if you think about that, what was the underlying motivation and ideology besides, potentially the desire for a dollar? It was because groups were finding it increasingly difficult to evolve, to put in systems of care that actually manage care as opposed to managing costs. And I think Rick's reference to managing care is different than the managed care that I foresee in the future, and the managed care that I think many of us in the room actually engage in. And that is managing care as opposed to managing costs, because historically managed care didn't do much to manage the care, it did manage the cost. And you need tools to manage care, and I think that's one of the advantages the Affordable Care Act has afforded. Health plan consolidation also put pressure on physician groups, as individual providers found, as the graph that we just showed with the increase in premiums, that health plans looked at groups really just to reduce, again, their unit costs. And in my mind, there's a limited ability for unit cost reduction to be effective. There's a point at which if the unit doesn't pay for itself, the unit has no value. And many of us that provide care in the Medi-Cal space, have seen that that unit has been reached in some cases. So improving the health of the population, how does the Affordable Care Act do that? Well, first and foremost, if you cover more people, you tend to get better outcomes. If patients approach their healthcare delivery through one-op, sort of episodic care in the emergency room, it doesn't lead to management of chronic disease and better outcomes that you see with that. Meaningful use, again, with the EMR adoption, has given us the ability to do true population management. Now, I left Orange County about a month and a half ago to join a national health plan and provide care at a national level for Molina, which primarily focuses on low-income and needy families. And my motivation was, if you see where health, at least from my perspective, where healthcare is going, it is an opportunity to now start to coordinate and organize systems of care and get away from unit costs, because unit cost is designed to mitigate the 30 to 35% extra procedures done in care. And so if you can eliminate some of the excess care, the excess services, provide care at the appropriate level in appropriate locations, then you can make it affordable. And you can provide care, better care, population-based care to more people. I like this slide because it says a lot. And that is, if we have a system of care that's based on delivery of services, the more services you render, the more money you make, and the higher the cost of care, regardless of whether it improves the health of your patient. So one of the things that I like about managed care is it gives a provider the opportunity to be a purist in their approach to healthcare. You don't have to do wallet biopsies, if you guys remember that term. So reducing per capita costs. I talked a little about my perception of my perception of the limited effectiveness of unit costs, but right now that is the primary lever that the government has to pull, and they keep pulling it again and again. At some point, though, I think physicians have to figure out how to deliver care better and more efficiently so that we have a different level of care, lever to pull for care other than reducing unit costs. I think physicians are going to have to move into larger, more organized, more efficient delivery systems and delivery models, pooling resources and pooling, both all resources and having better access to data and be able to manage patients on a more population-based level. Risk stratification, what does that mean? To me, that means if you look at, healthcare costs by population, you find that there are outliers in any population, and if you can figure out who those outliers are, target your care to the people who need it most, then you can reduce the total cost of care for your population. That means being organized, preemptive, and proactive in your approach. So, is he dead? Not completely. I mean, I think there's still a role for the solo practitioner, but I think that role is changing. I think docs are going to have better ways to deliver care than Marcus Welby had. That mechanism, I think, is on the wane. Most physicians who are coming out of training now are looking for employed status. Very few of them are hanging their shingles, and very few primary care doctors are hanging their shingles and say, come see me. I think we'll have to see an increase in mid-level practitioners. If you look at projections, by the year 2030, there's anticipated 125,000 physician shortage. You're not going to make that up. There's not enough throughput in the system to graduate enough physicians to fill that gap. And so mid-levels will solve that problem partially. But again, reorganizing the approach to care is probably going to be more relevant. The Affordable Care Act, and prior to the Affordable Care Act, increasing transparency in healthcare is the fact today, and it'll become increasingly tomorrow. Health plans are very conscious of their star ratings and how their report cards look because people make decisions about whether we use them or not. And for the Marcus Welbys that won't go away, I think there is an opportunity for niche practice, and there is a second industry growing up around that, where people will pay for concierge medicine, and you'll take an increased amount either on a per member per month or on a monthly basis to provide 24-hour care, and that will survive in some markets, but I don't think that obviously can satisfy the demands of the country. So in closing, healthcare is in transition. There are a ton of patients about to watch on the shores of healthcare, whether we're ready for them or not. Will we be washed away, or will we figure out ways to channel that water safely and effectively inland or back out to sea? So thank you, and I look forward to your questions.
Thank you, Keith, President, Molina Medical Groups. Now, question, how many of you are graduates of master's, MBA graduates of UC Irvine Paul Merage School of Business? How many of you? So there's a number of you, and you're all students of Paul's, right? Paul Feldstein? Well, we have another one up here, and that's Chris DeRosa is an alumni, and Chris has been in Orange County, and actually lives in Orange County, and started with Cigna, and is continuing with Cigna, has grown with Cigna all his career. So, Chris, we're delighted to have an Orange Countyan, another Orange Countyan with us today, and please come on up.
Thank you. I wasn't really worried about the time. I'm used to provider risk, so I was good to take that. But both appreciate your comments. They've made my job a lot easier in a lot of ways. For those of you who are going to take notes, the slides are available on our website, so don't feel like you got to take copies. You can do that. It's a broader deck as well. I only took a few. I'm not an overly big fan of PowerPoint except for pictures, and I've got a couple here that I just you can't sort of hand do a graph. Back up here. Employer mandates. First, I will cede absolutely the ACA is all about access. It is not about quality. It is not about on how we work through that. It is not anything to do with how we work as a delivery system, how it is organized, and it really isn't a healthcare reform. It really, if I could rename it, I would rename it the Medicare Sustainability Act with a little bit of insurance reform. That is probably what it would have been better at. A lot of misnomers about it, so I thought what I would do is I'll take you through a couple of points. One, I'll talk to you a little bit about the employer mandate, what it looks like, and then I'm going to come back and I'm going to talk to you a little bit about the access points that were made in here and what risk pools look like, and then it will give you a real clear idea why all the insurers did what they did relative to it and where I really think the opportunities for us are as an industry. So. If you have an employer with 50 employees, but under 100, you're going to be impacted by the where ACA is. Large employers are not until 2017. So everyone who sort of thinks Walmart is going to drop their employees come January, they are not. They're not going to go through that. The other part that I think is a misnomer is everyone sort of looked at size and says, geez, we think all sorts of small employers are going to put all of their employees into an exchange and the larger employees will keep them. I don't think that's true either. And by the way, these views do not necessarily reflect the views of the station and or its sponsors. They're my personal opinions here in those areas. So before you go, all Cigna people are there. I think it's about your relationship to labor. I know a lot of the CEOs in this marketplace, here in Orange County, particularly stay in Orange County for a second, medical device manufacturing firms, a lot of biotech firms, they are never putting those scientists on an exchange. Not going to happen. That is their business. I know a lot of large employers where they have a lot of part-time employees or near part-time employees. Their training costs are very easy. It's not very good. They are very likely to put their employees on an exchange because they can turn people over. There's not a big cost investment on it. That's what I think you're really going to see how employers make their decision is a lot about their relationship to their employees will be reflected in that benefit choice. Minimum value, I want to make sure I just cover that concept. So it isn't enough just to offer insurance. You have to hit the minimum value as described by it. And they use a lot of benchmark plans, some very affordable and skinny plans like the state employee benefits, like some of the richer plans in the small employer market. And they used Kaiser's plan as well. And that's where they came up with sort of the minimum value of it. As you saw in the news articles, that value is substantially greater than the individual market is today. So what's covered is much more comprehensive. So when you do get access to it, you will get substantially more things covered than are covered today and should mean a less out of pocket for folks who are on the plans. Employer penalties, incentives to see the economic decisions that will be taking place. And so this is the chart I really wanted to run through. So the first question is, do you offer coverage when you work with an employer? If the answer is no, you get a $2,000 per employee. For some reason, The first 30 were excluded. I don't know why, but legislation is what it is. So if you have the first 30, we're going to spot you those, but everybody else after that, $2,000. If you do offer it, the next question is, did you hit the minimum value? And so there's going to be a lot of work being done for employers to figure out that their plans actually hit the minimum value, do they not? And that's one of the questions we're working through with employers. If the answer is no, you get the lesser of $3,000 per employee who receives a tax credit, and the $2,000 per employee, again, minus the first 30. And I'll show you an example of what the dollars look like for an average plan. And then is the coverage affordable? So this is one I think a lot of employers are not paying attention to, and that is the coverage, what you charge the employee for their coverage, has to be less than 9.5% of their family income. Family income. I'm sure you're all familiar with what all of their spouses and others are making at home to make sure that you know that it's less than 9.5% of their family income, right? Yeah, me neither. As an employer, I have like 2,500 employees, and I have no idea what their family and spouses make whatsoever, and we're going to have to figure that out. So the only safe bet, if you're an employer, is to make sure that it's 9.5% of their income, and then for sure you know where you're at. No, you go back to the penalty if it's not. So those three questions are really what has to go through. And if you do manage to answer yes to all of those questions, there is no penalty involved. So some example, 500 employees, no coverage. One employee, so how the trigger, how they know you don't have coverage is one of the employees shows up on an exchange. So if they don't show up on an exchange, federal government never finds you, right? The great thing about America is people are really entrepreneurial. As many of you are in this room, people are really good at figuring things out, and there's a boatload of unintended consequences that are going to come from this law, in my opinion, as you go through it. This will be one of those areas. As long as they don't get on an exchange, you don't have to pay the penalty. But once they do, you get a penalty minus the first employees. So 470, because again, we don't count the first 30. 2,000 employee, there's your penalty. So that's the employer's penalty for not. For those of you who are actual employers and you actually had 500 employees, I want you to think about what $940,000 is versus what a medical plan would cost you to put in place. It's worth the risk for a lot of folks. A lot of people will take the risk that they don't get caught because the 940 is so much less than what a benefit plan might be for 500 employees. 1,200 employees, not affordable. There's the trigger. I'll take you through it. So you get the lesser of the penalties, depending if you're not affordable. Again, this is if it turns out they do the analysis and the 9.5% of their income, it's greater than that, and people go to an exchange to get their coverage. This is what it would look like. This is the penalty you would pay. Once again, if you're a 1,200 employer group and it's not affordable, you're probably a lot better to leave your coverage where it is and risk whether or not the feds are going to find you or not going to find you. Individual mandate, family of 4. These are the penalties for individuals, and you can see how it goes up over time. So I want you to think about what an annual coverage would be for individuals relative to it and whether or not they're going to go. A lot of the examples they use, and something to keep in mind, is they always use the $95. The $95 is applicable at 150% of the federal poverty rate. For an individual, that's somewhere like around $11,000 or $12,000 is the federal poverty rate for an individual. So we're talking about individuals who are really not making a whole lot of money. As you move up the scale, it grades from there. And in every one of the places that I've seen afterwards, the economic incentive is to the penalty and not to the coverage. Because the penalty, keep in mind, is paid annually. That $95 is an annual payment. The $250 is an annual versus a monthly cost for insurance. So that there. Why am I taking you all this? Is not to take a dim view. As Rick and Keith had pointed out, the most important part of this is going to be a viable risk pool. That's really what this all comes down to at the end of the day. While Thomas Jefferson did say all men are created equal with certain inalienable rights, and I know he meant women at the time, he just wasn't sensitivity, and I know he's going through that training now. So all of us would be. But they're not all actuarially equivalent, as it turns out. And one of the tricks is going to be, can we get a pool that is sustainable and get enough people today off the sidelines who are healthy into the pool versus not? And that is really going to be the question that happens, and that's exactly what the speculation will be. And it won't be a year one problem. So everyone is waiting for it to crater like in February. That is not going to be when this hits. When it's going to hit is 2 and 3 years later. So the first year will go in, everyone will get their coverage, they'll work through it. If not enough healthy people are in, the increases in year 2 will be dramatic because you have to take the health of the cost of the people who are in the pool. You're going to have to make sure we can get up to that level. Then the people who are on the margin who now make the next economic decision drop out in year 3. That continues to escalate. It's known as a death spiral in technical insurance terms. And that's where you end up with a pool that is not sustainable. And we've seen it before. You've seen the high-risk pool, Mr. Mibbs. You've seen it. There's many examples of where longer term you have pools that just don't survive going forward. The fees, one of the other things that you're going to see. So right now the incentive, employers probably to stay pretty much where they're at and wait and see what happens. The other real incentive that's in there that I don't know was intended, and that's a move to self-insurance. So one of the other things you'll hear a lot about in the health insurance is, do I stay insured or do I go self-funded? There was an awful lot of taxes and fees that were added to help support the law and the costs that were going to go in, but they only applied it to insurance plans and not to self-funded plans. So as you can see now, there's now a big change in the costs that come in being self-funded versus not. And you see a lot of employers and employers down to 50 employees moving to self-insurance. Because remember, if you self-insure your plan and you put and I'm going to use insurance terms, and I apologize, but an aggregate stop loss that basically stops the overall cost of the plan, and a specific one that keeps any one large claimant, protects you from those, you can actually get quite a very manageable, predictable, budgetable risk corridor for a self-funded plan and protect yourself. Looks and feels a lot like a fully insured plan, but its base is actually ERISA based versus state mandated base, and you end up with an ability to avoid all those taxes and fees. Historically, the risk corridor was not worth it. But now with the changes it is, so to give you an example, if you have a $5 million plan for a large employer, the actual cost with the fees on the insurance will take your actual out-of-pocket to about $6 million. If you had the worst case scenario under a self-funded plan with a 25% corridor, you're only going to be at $6.15 million. And the chances of that happening are smaller. It's about 70% likely that you'll end up below that versus not. So there's going to be a lot of moves to self-insurance, and you'll see a lot of legislation as the commissioners begin to worry about whether or not we need to do something about capping or making self-insurance unattractive so that employers don't opt out that way. Business strategies, I want to talk through the options. This is really the graph I wanted to show you all, because this is where I think is going to is going to tell you what employers do. If you have involvement with your financing on one axis and involvement with the benefits, health, and productivity on the other, and what I would put that graph in is your relationship to labor. How much do your employees really matter to you, and how much do you want to be involved in the financing? If you really do not want to be involved in the financing, but you really care about your employees, you will probably stay the course. You'll pay the additional fees and you won't do anything, and you'll stay where you're at because that is going to be the best option for you. If you really care about your employees, but you're very flexible on your funding arrangements, because that's really when we get back to what our two previous speakers talked about, is you have to improve the health of your employees to make sure that you can afford your costs on a go-forward basis, and you'll look for those innovative kind of employers. This is where you're going to see those employers begin to show up. These are your Safeways of the world who want to improve the health and productivity of their employees and stay here. This is what I'm seeing in a lot of the employers, even here in Orange County, are doing. It's a lot what St. Joe's and Hogue are working through. If you really don't care about your employees, but you're sophisticated with the financing, this is where the private exchanges come in place. This is where I really don't want to be involved, too much, but I do understand the financing, and I don't want to end up on an insured product because I can see it. This is where you see a lot of those beginning to emerge, and you're seeing a lot of private exchanges begin to emerge in the marketplace. Yet to take off, still have the same kind of issues around risk pools, but they're more manageable in an employer because an employer already knows what their risk population looks like who are doing this. So today, if you are Intel, and I'll just pick on them if there's any employees from Intel here. No offense, I have no idea what they're doing with their benefits. But if you pick on them, and they were going to go to a private exchange, they already know what their employee population is. They've had data on them for a while. They know what it looks like. It's going to be relatively easy for them to forecast how it's going to work. So a private exchange may make sense for them in a lot of ways. And if you really don't care about the financing and you don't understand how to do it, it's really too complex, and you really have an employee population that you can turn over on a regular basis, no real big investment in training and others, you will send your employees to the exchange, because that is going to be the easiest option for you to do. That is how we believe the market's going to parse itself out on a go-forward basis. And there's a lot of implications to it as well. And you started to hear them. So again, unintended consequences, one of the things you're seeing is you saw access, and access to what was one of the questions Dr. Family asked? Well, that's true. If you look at the plans that are on the exchange, they're all narrow networks. They're really narrow networks. In fact, at this point in the exchange, I'd have to go back and look to ensure, but I don't even think UCLA is available on the exchange. It has been carved out along with Cedars on so many of the networks for the Blues plans. There may be no access for the people on it to it. You're going to begin to see, I believe, a lot more tiering of the networks, but beyond just sort of here's a high, here you pay more copay, less copay, access is going to begin to get restricted. And you're going to see those who are more aligned with the CalOptimas and Molinas and really understand how to control that cost and can make money on a Medi-Cal rate, really begin to make money and focus into that marketplace. And if you think about consumer choice, there's going to be those who do want to take a view of the bed over the bay, and they're not going to want to go to one of those facilities, and you're going to see them pay more for those, and you're going to see a tiering of the system. Those who are in the exchange, those who are in the public plans, those who are private pay, and who are not. And every other industrialized nation that has moved to this kind of program has that kind of tiering. And it's not all bad, because you get really efficient on what you do here versus where you're willing to pay a little bit more and different. The question is, will you be at equal outcomes out of it? Will you be able to get the quality and the outcomes and those kind of items? And there will be a whole lot that we'll go through as a society with that. We'll fear it here in Orange County. There's definitely communities in Orange County that are much more aligned towards Medi-Cal, and there's ones who are very much not. And they will definitely begin to, you'll feel that more and more if this really does take off in a lot of ways, because that's really where you're going to have to get to. Coverage, and I don't know where we are in time, maybe 5 minutes. Maybe that was like 5 minutes ago when you told me that. No, but okay. It's all about risk, right? What'll really matter when we get to it, and you'll see the move, again, the tiering that'll take place on that, it'll really matter is to whether or not we get the pool. And the last part I'll leave you on that is the uninsured today, who they are. 11% of the uninsured make more than $70,000 a year and are employed today. They are choosing to be uninsured. The vast majority of them, a little over 30, a vast majority of them have access to coverage today, whether it's through SCHIP, whether it's through Medi-Cal, whether it's through their employer. I think it's a little over 2/3 have access to coverage today and just choose not to do it. How many of us have you seen out there? We still worry about uninsured motorists, even though we have a mandate on auto insurance. We have mandates on workers' comp, yet we always hear about employers that don't have workers' comp on it. We will still have an uninsured population. It really will depend on which parts of the uninsured population become covered and how we're able to manage that pool as to whether or not it's going to be successful and how many enroll. And that really will be the thing to watch, is how many enroll, what they enroll. We're going to spend a boatload on it. I think California is slated to spend $285 million between July and October in order to advertise on it. I mean, if you think political campaigns on TV were annoying during the election season, you haven't seen anything yet. But the question will be, if you're the demographic they're looking for, where they're advertising, whether you see it. But it is going to be pervasive over the next few months, and you'll see why. The reason why is because they have to get a pool that is stable if it's going to last. I will stop there because I know we're going to have a ton of questions on it, and I don't think I had anything other than consider a strategy. This is where you can get the slide deck, and it's a much expanded slide deck online that you can get from us. And this is the legalese that lets you know that it's a company and everything else, and it's not reflective of it. And if you should go get professional advice or something like that and make sure they got on there. So.
What a great summary and great perspectives we get from three different views. But you know, they're all pretty much, there's so much similarity in that. So this is still a beginning of a journey that we're all on. And thank you very much for sharing your thoughts on this. And so we have the opportunity for questions at this point. So we have one right away.
My name is Tom Bate. I'm a family practice doctor in solo practice in Orange County. Thank you for the talk. It's excellent. Can you talk about the MICRA that's going on in the States and how that will affect the concept of the changing world that we're now with the new ACA and the legal climate that's always in the back of my mind when I see a patient?
So the question for those you couldn't hear is, what's the impact? All of this is going on. How does MICRA impacted by this, or how does this impact? What's going to happen around that? And any of the panelists like to speak?
Yeah, I'll take first shot at it.
You know what?
Can
I'm
you
going to
guys
do
hear me?
something different, by the way, Keith, because Ed will never be able to see anybody, because
You want me to come up there?
yeah, probably ought to come up here. I think that'll. Sorry to do that. We have all these microphones, but everybody wants to see your faces. So
Or we could move the,
maybe we can move this back. Is this movable?
anybody?
Here goes. No.
Oh, not with the water here, at least. I think what you're asking is, what has been a pretty pervasive physician backlash against the Affordable Care Act, and that is that it didn't go far enough in sort of two parameters that at least the AMA thought that they would embrace, and one is legislation for tort reform and protection against malpractice suits. There were two versions of the ACA Act, one out of the Senate and one out of the Congress. At the end of, in the 11th hour, when it all started to kind of come crashing down, the Senate one prevailed. There were more protections in the House version, but that obviously didn't come to fruition. So, I mean, the other piece I think that physicians are angry about, obviously, was the lack of tort reform, which was, sort of an unkept promise. And then secondarily was the lack of a fix for the SGR, Sustainable Growth Rate, which, if it was allowed to come to fruition, I think at this point we're looking at a 27% reduction in Medicare reimbursement. So there is discussion that, there's a percentage of healthcare costs that's related to defensive practices of medicine. Right now, to my knowledge, MICRA is not under any undue challenge. Every year or every number of years that it comes up for renewal, the trial lawyers go after it, and it has always managed to prevail. And I don't think that is going to change in this iteration as well. So I think we are protected in California from a MICRA perspective. I think your point's a good one in terms of sort of national policy, in that there was an opportunity missed to enact some tort reform.
Thank you. Any additional comments? How about other questions? Oops, yes.
Yeah, hi, my name is Mark Cormany. I'm a broker in the community. My question's for Chris. Hey, Chris, long time no see. Could you speculate possibly on why 3 of the large national carriers chose not to participate in the exchange in California?
Did everybody hear the question?
Can I speculate on why the 3 large employers didn't go into the exchange? I can speculate, it turns out. It would just be that. It'd be speculation. I'm not knowing anything on that sort of thing. But if I were to speculate, and I would tell you it's about risk pools, I would think about who is in the individual market today, right? That would be Kaiser, it'd be WellPoint, it would be Blue Shield. And if you really wanted to know the population you were about to take on in an individual market like that, it'd probably be really a good idea to start with your own population, right? And so you could market heavily to your own population. You know who they are, you know what their costs look like, you know where you would get them. So you'd probably want to stay in the exchange and market heavily to those. If you were not in the individual market today in a great degree, but only had a small exposure to it, or were only involved in a small way, you really might want to wait and see what that pool looks like before you decide to jump in on a committed basis to it. And so you might want to wait until you took and saw exactly who enrolled and who didn't. And you also would know the people in order to solicit the kind of best actuarial, kind of component to get into. So you might sit on the sidelines. If I were speculating, that might be what I would look at.
Very well. Question?
Hi, I'm Ramala Batra. I'm a medical director at Scan Health Plan. So I notice around us there are a lot of physician groups that are integrating with hospitals, physician groups that are working with plans. There's the triple aim, we want best experience, we want population and management and all those nice things. But being on the plan side, I don't notice a lot of hospitals approaching us and saying, hey, you have so much of population data or tools. Share with us. See how we can cut down on costs. So give you an example, care transitions, right? Hospitals doing it, the physician groups are doing it, we are doing it. All of us are doing it for the same patients. So it's not improving the quality, it's adding to everybody's costs. But we don't see that kind of dialogue outside of an ACO or outside of an Optum buying a Monarch or somebody else buying a physician group. Do you see any change from the hospital side, especially hospital side, to kind of engage with people who hold the data or have held the data for years and years?
So the question is, how can, between hospitals and medical groups probably, and insurers, can more patient information be exchanged so that will help patient care to have the information broader? And it's done maybe with ACOs and some pilots, but it's not being done very broadly. So could that be addressed? Sounds like Rick is going to give that a shot.
I am. I can always depend upon Dr. Batra to give me a tough question. Thank you, Ramila. So I'll be a little provocative. I would say that most of the lack of activity between hospitals and health plans has been motivated by the health plans, not by the hospital. We have been trying to get data from health plans forever and have been rebuffed on numerous occasions. And the reason is, I believe, if I were to speculate, the reason is because the margin is created by he who owns the data. And if you have the data and you have the ability to manage that data, that's where you can control how the funds would flow. And so sharing the data means you're going to put that benefit at risk. That's changed, however. And so you mentioned ACO, and so you should know that we, both at St. Joseph Health as well as Hoag, have had private ACO-like activities on select populations that have now been going on for a year or two, in which we explicitly set the parameters of the engagement between the hospital and the health plan such that it was win-win or lose-lose, and the data that then led to the management was going to determine whether it worked or not. We have far succeeded in both of those ACOs than either parties thought it possibly we could have done, to your point. However, what occurred, however, is that now there is shared risk and shared reward. And that shared reward part has not been very well thought of or embraced by many of these siloed parties within the healthcare arena in the past. What that has done for us as a hospital system is that it has shown us that we can partner with health plans, and that when we do, we can do some pretty darn good work, mostly around the data, somewhat around the network of care, not so much around what I'll call the care management processes, which I think, for me personally, have been okay, but have not been such a significant degree that they make a necessary difference in how the care is provided and then ultimately how much it would cost. So I think the bit of work that we've been doing recently has shown that your point is correct, that when providers, health plans, and employers begin to collaborate in a meaningful way around win-win relationships that are powered by the technology, empowered by the information, that it can be very, very significant. And ultimately, at the end of the day, the greatest benefit goes to the patients in better care, but also in lower costs for them themselves. And so that formula seems to be a formula that many who are embracing this transformative time are trying to envision and are trying to put plans in place that might actually embrace those facts. I think your point is very well taken. I would have a little bit of a problem with the cause of that, but that's looking backwards. I think going forwards, that those relationships have to occur, otherwise we'll have no chance. And the alternative, of course, is get back to everybody in their silo and let's try to cut up the pie, and I'm going to work hard to get the biggest piece of the pie possible. I don't think anybody wants to do that. So we need to change the nature of how we work within that.
Terry, I just wanted to.
That's very well put, and I think some of the promises, or you want to,
Just want to
go ahead, Chris.
I agree with exactly what he just said, that I don't want to look retrospectively, but on a go-forward basis, it has been the partnership, the ability to see facilities and physicians as collaborative partners that has made the difference on sort of the data sharing and the others. It's been a much more trusting and less adversarial relationship, I'd say, in the last 2-3 years than I think it was historically. And Rick is so progressive on it, for lack of a better word, without all the connotations with it, because I have no idea where you were on that part. But I would say that it's there are still quite a few facilities and others out there that see the adversarial relationship, that are still into the we'll take your data and use it against you kind of thing, and there's still a lot of that kind of it, but less and less. More and more I see the ones who are willing to partner and really thinking about how we're going to go forward into the marketplace. And so you should see it evolve over time.
Again, well put. And I think this is one of the promising aspects of the Affordable Care Act is that this is pushing this type of collaboration together. And I know in University of California, in our health system, that this is beginning to happen too. So it's an advancing opportunity for all of us. Question, Dr. Kane.
Opportunity for them to be partners in all this and to get into managing the population health with them on a global fee rather than episodic of this is the amount of this drug costs you today and so on. I wonder if you can comment about that.
So the question, Dr. Kane, is there an opportunity to engage and get involved and partner with pharmaceutical companies? And because of the cost of care involved, cost of the drugs in care, is there a way to develop some kind of mechanism that will cut that cost and work with them more closely, and where they're a part of this opportunity to improve care and decrease costs? Rick?
I'll just make a comment. Ed knows what I look like now, so I think we're okay over here. Don't quote me on these facts because they're not quotable, but the concept is correct. Healthcare is approaching $3 trillion business. 1/3 of the healthcare costs are somehow related to pharmaceuticals and the whole drug industry, but half the profits. Okay, don't quote me on the percentages, but the concept is correct. So to Dr. Kane's question, if that were the case, why in the world would I want to change that? If I'm Pfizer, if I'm any of them, why in the world would I want to change that? They'll take the taxes, which they're taking on the, they have a 3% tax, and hospitals are given their part, and health plans are given their part. I think only the doctors got out of this without having to do much, as it relates to contributing to the Affordable Care Act. But the pharmaceutical industry still is looking at 20 and 30% margins, if not greater, even net of the taxes and the costs of the Affordable Care Act. So they're going to do everything in their power, because remember, they're publicly traded companies who have a responsibility to their shareholders. The point that you're making is we could do so much better if we didn't have that largesse and that excess that relates to where the pharmaceutical industry is. What I think is going to happen, and what we're beginning to see now, is disruption by others who are bringing to bear elements of what drug distribution and medication distribution is all about. They're the disruptors. Walmart, Amazon is going to be a tremendous disruptor in medication management. And so we're seeing a whole new set of entrants into that distribution element, and so that's what's going to change the marketplace as it relates to the manufacture and then the ultimate providing and distribution. Because if you look at any organization that Walmart has to deal with directly, the distributor, which is Walmart, takes the profit margin out of the manufacturer and the middle persons, whoever they might be. And so that disruption, I think, is going to change that. But in the meantime, there is not going to be, I think your point is, why don't they just come to the table and we can do all things better? And my answer to that, the reason that's not going to happen is 30% margins and shareholders are not going to allow them to proactively take that piece until they can see that there's no chance that that can continue. And I think the disruption of that, if it isn't regulation, and Chris, I'm sure you have a lot of PBM experiences with folks who are doing this sort of thing, but if it isn't regulation that takes it out, and the way they try to regulate it by making a tax, and the tax is far insufficient to cause drug companies to take a different point of view. Much like the Affordable Care Act has driven us together, Terry, I don't think that it has had a sufficient part on the drug industry. And they're just doing what they do well, which is to make money and provide benefit to their shareholders. That's what they do primarily, besides serving the public and creating good drugs. So that would be my answer to that.
Chris or Keith?
I actually don't have anything to say. He said it all.
Yeah, I would agree exactly on the motivation. And I would just go, as you look future state, I think it only gets worse, right? Because really the drugs are now becoming very genomic specific, and they're really moving in. And so your ability to have a very small supply to a very great demand is going to continue to drive those prices up and continue to have them hold kind of the space that they've got right now. I don't see that changing anytime in the near future.
Okay, question over there, and then a question with Dr. Dar.
Dr. Chris Colbert, Chief Medical Officer of Precept. I have a follow-up question to comments from Rick and Chris regarding the role of employers, and specifically I'd like to look at in Orange County. More than 80% of self-funded employers have a very significant investment in wellness and health promotion programs. They average between $200 and $300 per employee on the programs, between $300 and $400 per employee on the incentives. They're reaching through to spouses and dependents as well, since that's where a lot of the claim costs are. Many of these employers are very eager to partner with health systems, and especially with providers, around community-based improvements into the health of populations. For their own reasons, that's who their employees are, that's who their future employees are, but also many of them have a significant investment in their communities. The challenge they face in Orange County is what I'd like to hear your responses to specifically is, what's a forum where a large number of employers can come into alignment with providers around specifics of targets, of activities, of incentives, which, again, I think many of them would be very eager to support.
Did everybody hear the question? No. So I think there's, you were talking about businesses in terms of their desire to improve the health of their employees and staff, and how can there be an opportunity to work with providers in order to be able to make an impact in this regard? And what kind of forum might be established to have these discussions? Is that fairly? Okay, Chris, you look like you're going to start with this.
Sure. And good to see you, Chris. I can always remember his name. It works really well for me. I think the forums, I mean, there are some that start to form spontaneously, so you start to see some around the chambers. You start to see some around groups where you have employers of like-minded that have gone in. There isn't an official, I have not seen the Employers for Wellness Foundation board that is formed yet, but at some point they may go that way. We do tend to, I think they'll also begin to coalesce around their carriers and providers in the marketplace who are of like mind. All of our, and I'm not going to get into sort of a competitive thing here, but we each have very different value propositions as to how we go to market and why we're trying to drive sort of the improvement in health or wellness versus not among my competitors. And you'll see those of us who are more on the wellness and health side begin to sort of amass and coalesce around those employers and around those provider systems that are also of like mind. And again, you'll see it stratify out to those who are not from a model standpoint. I have seen some of the facilities have those kind of forums, and I know, Rick, you have, and so maybe I'll just transition and let you sort of talk through your experience there.
One of the reasons why healthcare providers are beginning to come together, whether it be in consolidation, affiliation, or just a willingness to work collaboratively, is to address the employer community. I think we've alluded to that. And so there is willingness of the providers now, and you had mentioned you're hopeful that the providers could do that, Chris. There's willingness among the providers to do so, and I think the Affordable Care Act and healthcare reform has been a big part of that because of the reductions in payment for unit costs. This looks like a better option, a better way to go. And we know the employer community wants this and is very focused on their escalation and the inflation of healthcare costs. So if I were to speculate why health systems in Orange County might begin to coalesce and come together, it would be just for that very reason, to create a means by which healthcare providers, whether it be Hoag, St. Joseph Health, or whoever it might be, the UC systems beginning to come together and work more collaboratively, will be to address that. So I think the forums will be there. It isn't as if we need to hold a conference, and we can do that, and we have nice conversations. But I think that employers and healthcare providers and health plans as participants in this, by the way, are now in a different place. And there is value created for all of those parties if they can work collaboratively in a specific example of what you just alluded to, which is the health of a group of people who work for a particular company, the self-insured company, et cetera, et cetera. So these times have caused those individuals to begin to come together. I don't think we need a broker community. I think that these folks will find each other naturally because the economics are such that this is the right time and place for this to occur.
Very true, and perhaps also this is an opportunity for Margaret and Paul, I mean, maybe to bring folks together in some kind of forum to discuss this also on a broad basis. I think we're getting down to the end, so Dr. Dar.
Thank you so much, Terry. Jay Dar, Chief Hospital Orange County, UC Revenue Decision. Majority of the audience today is physicians. We saw that in the show past. I'm glad to say that the speakers are all three physicians, one representing large hospital system, one healthcare system, and another the insurance industry. My question is, from the standpoint of providers, and we have moved forward, we have moved forward, but we
So as I understand the question, Dr. Dar, it's for physicians, as we look at where we're heading and looking at relationships with hospitals, with integrated systems, with health plans, all of what's going on here, what is the relationship? What is foreseen possibly as a relationship with physicians moving forward? Is it employment relationship? Is it a foundation relationship? Is it a joint venture? What form? Does that, that's your question? Okay, Keith?
Sure. First of all, I think it's all of the above. I don't think there's one single model that will usurp or replace all others. I do think, though, that physicians have an opportunity to become engaged in positions of leadership, and that they should seek those out and become more involved, in the delivery of care and in creating the platforms and sort of coordinating and organizing the structure and the approach. Because physicians have a unique perspective that's different than most other business people or lay people, and they get it in its totality. I think docs have suffered, though, from a certain extent, from not paying enough attention to the macro business, beyond what impacts them within their four walls of their practice. So from my perspective, I am in fact, looking to actively engage, involve physicians in dialogue, and creating, inviting them to be part of the solution. I do think, though, as I mentioned in my talk, that the generation of physicians today, or historic physicians, is a little different than the generation of physicians entering the marketplace. And if you look at Generation Xers, their expectations for lifestyle, for balance in life, and willingness to work the hours that hardworking entrepreneurial physicians of the past, that's sort of sunsetting. The number of docs that are retiring is obviously greater than the number of docs coming into the market, as based on demand, as we saw the supply gap, well, I didn't show it as a graphic, but there is in fact a widening need for docs. So I think docs have a choice. I think it's going to be increasingly challenging, though, to hang a shingle and set up a individual practice. I think, if docs want to collaborate in small groups, medium-sized groups, and not necessarily mega groups like, some of us, like I represent. But I don't think there's a single answer. I think not whatever, but there are opportunities for physicians to be involved in the solution, and they kind of have to, pick their poison.
I think our time is up. So I think let's give it a round of applause for our outstanding panel.